Our everyday has encountered sudden change. COVID-19, the cause. We're making necessary adjustments. But just what should we expect with living in the new normal? Hello, I'm Marcia Kavanagh, and thanks for joining us for the first episode of a new WYES series, Living in the New Normal. The COVID-19 pandemic has forced us to make changes in our everyday lives in an effort to try to keep us healthy. Joining us now to discuss what to expect in these coming weeks and months, our New Orleans Health Director, Dr. Jennifer Avegno, City Health Director, University Medical Center Director of the Medical Intensive Care Unit and Pulmonologist, Dr. David Janz, Director of the Master of Public Health Program Epidemiology at Tulane University and also an epidemiologist is Dr. Susan Hassig, and Dr. Leonardo Seoane, Ochsner Health Chief Academic Officer and also Associate Vice-Chancellor for Academic Affairs at LSU Health Science Center in Shreveport. All right. Well, we have really been, we've gone through quite a couple of months, almost 3 months now with this pandemic. And we were hoping that, we had plateaued out, lowered that curve and that we were going to be able to keep lowering it. However, Dr. Avegno, we're seeing the numbers go up, and that is just really disheartening. How bad is it?
Well, it is concerning. You're right, Marcia, and thank you for having us here. Statewide, our cases are going up significantly in the last week or two. We know that COVID was never gone. There was a first wave, and I think the expectation might have been that it would go away and then maybe come back in the fall. But COVID never left Louisiana or anywhere else. We had suppressed it to a very low level, but now, unfortunately, as we've eased restrictions, we are seeing new rises in cases, particularly among young people.
And, that's an issue there where, young people, during these first few months, we've seen really young people not being impacted that much by this disease. So are they maybe feeling a little bit too, invulnerable here, where they really aren't going to get ill with it? But what do they need to be concerned about?
Right. Well, what we do know in our 3 months or so of tracking the virus is that in general, children, teenagers, young adults have milder cases. But that does not mean that we have not seen serious illness, hospitalizations, and deaths among this age group. Mm-hmm. And even more importantly, even if a young person doesn't feel very ill or doesn't need to go to the hospital, they can easily spread it to a loved one, parent, grandparent, older family member, someone with medical conditions who's going to have a much higher chance of serious medical conditions. And so perhaps they are feeling like this is over, or they can loosen up their guard or, do the things that they enjoyed doing before COVID, but that's absolutely not the case for the foreseeable future.
Because we have seen some large gatherings, apparently, here in the New Orleans area, Baton Rouge at bars, and you guys feel that maybe this is why we're seeing the spike in cases right now.
Yes, this is what we've seen throughout this disease, is that it's super spreader events, these large gatherings, generally indoors, where people are in very close contact, where one case can turn into 20 or 50 or 100. We're seeing that now at the clusters you mentioned, the bars in Baton Rouge and graduation parties in New Orleans. These are leisure activities that did not need to happen, and now unfortunately are putting individuals at risk and putting us all at economic risk if we are forced to continue having more restrictions because of these few events. And,
this disease really is nothing to fool around with. It can make you really sick. Dr. Janz, let me bring you in here for a second, because, I know you have been there, on the ground level treating patients. How bad is this disease?
Yeah, and again, thanks for having us. This was and continues to be pretty bad. I remember when the first few patients started coming into the ICU at University Medical Center, myself and even more seasoned intensive care unit doctors were witnessing this, both the volume of patients and their severity of illness. And this was, to both degrees, something that we had never seen before. The number of patients and how severely ill they were. And these patients continue to be just as ill as they had been before. Thankfully, the number of cases in the intensive care unit is lower compared to March and April, but we still have new patients coming in every day that are critically ill with this life-threatening illness. So I'm no less afraid of COVID-19 than I was back in March and April. I'm more reassured by the systems that we have had place and that we've refined since then, so that we're able to deal with these patients when they come in and take good care of them. But we do not have a cure for this disease. There are folks that will still die from this disease. And I think listening to our public health experts is going to be one of our best weapons against this disease.
And, we're hearing from our public health experts that one way to try to get a handle on this is testing, a lot of testing. And that was a problem in the beginning because there wasn't much testing going around. And bring Dr. Hassig in on this one. So could you just sort of explain to us, when we go get tested, number one, how is it being done? Are we still having that long swab going up for the brain tickle, or is that changing a little bit? And then what are we finding out from the test, both the diagnostic tests and the antibody tests?
Well, thank you, Marcia, for having this forum together for us to talk about this problem. It is a real challenge to try and get ahead of the virus and its impact on the community and the population as a whole. And testing is our best tool. Looking for people who are currently and actively infected with the virus, which is what the testing that we hear about every day and the new cases being identified, is absolutely critical to be able to break off chains of transmission as soon as possible. So we have a couple of ways that we can test for that. One is the big long swab going to do the brain tickle, as you said. And that is looking for active virus tested through a mechanism called PCR testing. But we have other mechanisms for identifying active virus or the presence of virus particles that are now being able to be implemented at the point of care, for example. But the other piece of testing that ultimately we're hoping to use to understand better how far and how much of an impact this virus has had on our population is the antibody test, which is a standard mechanism we have used in infectious disease epidemiology for decades to understand who has already been exposed and infected. The challenge with this particular virus is we still don't have a clear sense of whether the presence of antibody really means and translates to immunity to future infection. And even if it does, how long that will last. So it is very, very helpful to us to understand whether we have 20% of the population or 60% of the population that has been infected. That gets to the idea of herd immunity. But right now, we're still trying to track the active virus and get ahead of it so we can keep it from growing and expanding as rapidly as we know it can.
We're a little bit better with testing right now, actually really a lot better than we were, at the very beginning of this whole pandemic. Let me ask you this. If someone worries that maybe they were exposed, how long should they wait? If they're not feeling bad, how long should they wait before they get tested?
Well, it's a tricky question. One of the things that we understand from identifying and tracking people where we know when they were exposed is that generally we don't start seeing the virus replicate to a large number and in adequate numbers to be detected by our best test, the PCR test, until about 5 days after they've been exposed. And often that is about the time when people will also begin to develop symptomology. So testing too early may give you a negative test even if you are in fact infected. So it is best to, I think, wait for 4 to 5 days before going to get the test, but acting and behaving in that interim as if you were infected so that you are not potentially starting to spread it even before you get tested.
Dr. Seoane, let me bring you in on this. I know Ochsner provides tests to its patients, to the public. Do you guys think that they'll get to be the point where we'll have home testing so that people would be able to just do it in their home and maybe do it more frequently?
I think there will be a point that, the University of Buffalo has done a lot of work in this area of actually a spit test and actually by mid-July, we hope to have a oral swab that'll be up and running to be much easier and you won't need the brain tickle, as you said. And so that'll be in mid-July, we'll be able to offer that to the public. So I think as science and technology progresses, you're going to see, and then there's these antigen tests that also could be a kind of a quick test result. So we are making some advancements there, but I think a home test is probably still down the road.
Okay, so we'd have to wait for that. So basically, there are testing facilities all around, right, Jennifer?
Yes. Yeah, absolutely. One of the real bright spots in New Orleans' response has been our level of testing. It started very early with our federal partnerships, with our drive-through tests, and then we shifted really before the rest of the country to doing community mobile testing. And that's in partnership with Ochsner, with LCMC, with LSU. We have outside partners, philanthropic partners, and because of that, we have been able to test at some of the highest levels in the country, which means we really do have a good understanding in real time of how cases are happening, where they're happening, and whenever an outbreak might occur.
And that contact tracing is really that's a big tool in the toolbox there to try to keep track, right?
Right. Testing and tracing are the keys. The state has set up several hundred contact tracers who are actively calling known positive cases, trying to find out where they might have been, who they might have been in contact with, and getting in touch with those contacts to let them know. Like programs all over the country, there have been a lot of challenges. Getting correct information for patients can be a challenge, and just having people pick up the phone when the contact tracers call is really important.
Okay. Dr. Janz, let me ask you this. For treatment, we've, from the very beginning, we've heard of doctors, giving certain type of medical treatments to patients, particularly for critically ill. But you guys really haven't been 100% certain what is the best. So what, over these months, have you found in treating critically ill patients?
Yeah, I don't think I can emphasize enough that SARS-CoV-2 is a novel pathogen that the world hasn't seen before until recently, but it causes syndromes and critical illness that is actually not novel at all. It causes sick lungs, can cause sick heart, sick kidneys, sick brain, for example. And in critical care, we've been treating these syndromes of these organs that fail for decades now, and have lots of evidence on how to manage these organs when they're sick in the ICU. Lots of evidence-based interventions to manage these folks and improve their outcomes. And I think the first treatment of these patients, especially when they become critically ill, is to not abandon your processes. Again, this is a novel pathogen, but it does not cause novel syndromes that we've never seen before. We've seen this a lot before in the history of critical care. And all of our processes of taking care of these patients with breathing machines, with other medicines to support their heart, with kidney support, et cetera, those things still apply to these patients and can still save lives. That's where lots of us in critical care in New Orleans and the region, from the get-go, we emphasize that and actually try to perfect those practices because that was our first defense against a large influx of very sick patients, was to get very good at doing what we've been doing well for a long time now. That's evidence-based. What is new over the past few weeks, there have been lots of quote-unquote experimental therapies that people have been talking about for the specific treatment of this novel pathogen, not of the syndromes, but of this novel pathogen. There are more treatments that have been talked about than there are panelists on this discussion right now. But there are probably only two that now we and our patients actually have the luxury of talking about more seriously as actually having evidence that these things may improve outcomes. And that's specifically a new medication called remdesivir, and using an old medication, corticosteroids, specifically dexamethasone, for the treatment of these patients with COVID.
We hear about convalescent plasma too. I mean, how much is that being used? And that's an age-old type of approach and treatment, isn't it?
Right. That's being used. It can be selected by a physician to use for patients. Currently, the Infectious Disease Society of America does not recommend use of convalescent plasma outside of a clinical trial for convalescent plasma. So it is not, nor should it be, in widespread routine use because we do not yet know if it actually benefits patients, and that therapy is not without risk.
Okay, in convalescent plasma, of course, you're using the antibodies from someone who has recovered or has had the disease at any rate. I know that there is research going on to actually manufacture these antibodies too, because antibodies could be good antibodies, and this is total layman's terms, of course, but some antibodies are stronger than others. So, Dr. Seoane, if you can, touch on that a little bit about research that's going on about antibodies treatment, manufacturing the antibodies, and then also, of course, ultimately the vaccine. Where are we with that?
Okay. So I'll start with the vaccine first, and I would say there's 4 leading candidates of the vaccine. I like to say there's the American one, the German one, the British, and the Australian one. And the American is the Moderna, and they are probably getting into phase 3 trials in July, they've announced. They're probably the leading edge there. Mm-hmm. The German one is partnered with Pfizer, which we will be a site of. And so in late July, we will be enrolling people in a vaccine trial here in New Orleans and offering the German one. Oxford is the British one. And then the University of Queensland, who's another one of our partners, is leading the Australian one. So I have some intimate knowledge into the German and the Australian vaccine. The important thing to know about the vaccine is, look, this is science at rocket speed or warp speed. It would take 3, 4, 5 years to develop a vaccine. We're developing a vaccine in 6 months. And one of the reasons Moderna has been out in front and ready to phase 3 is that they were working on a SARS vaccine and were able to just take some lessons learned and knowledge from that and kind of switch it. It's the same family. It's a coronavirus, just like the SARS-CoV-2 is a coronavirus. But the other important thing about these vaccines is that the leading candidates are novel ways to create a vaccine. They're not the traditional measles, mumps, rubella type vaccine. So because they're new, they're using mRNA or DNA or an adjunct to a protein to make the vaccine. We really don't know, is it going to give us the intense immune response we need to protect us? And then how long is that protection going to last? And then we have to walk a fine line because as Dr. Janz has talked, a lot of the morbidity and mortality from this virus is your body's response to the virus. You get this intense inflammatory response. So we'll have to be careful that walking that fine line that we want an immune response and neutralizing antibodies to protect us. Too much of an inflammatory response where we could cause harm by the vaccine. So a lot of work to do, but you will hear in the press that some people saying, look, we may have, if these studies are successful, by the end of the year, candidates for vaccination. And then to your point about antibodies, that science is incredible. I must say it's just incredible science. We've been working on antibodies to tumors, the cancer field, and a group out of San Diego has used AI technology because they had this incredible biobank of all of the antibodies, hundreds of antibodies, and looked at what could bind to the spike protein to protect us from the virus. And so they are currently doing animal studies. They're in the animal study phase of potentially antibodies and injecting you with a artificial antibody or say man-made antibody that will protect you from the virus. Incredible science, but we're far off from that being in front of humans.
So do you feel the vaccine, though, will it be, do you think, available? Because we keep hearing really 2021, practically speaking. Do you think we'll see something in 2021?
Yeah, as soon as you're going to see something that's going to be in wide use will be 2021. I think by the end of this year, we may have a lot of knowledge as to which one of these candidates will be effective. But then we've got to mass produce it. And be able to distribute it. Right.
That's another major issue, is that. And Dr. Hassig, I wanted to ask you to describe, we keep hearing shedding the virus. We were talking beforehand, I kind of, like I said, I sort of visualize my cat shedding. How does a person shed the virus?
Well, The first thing to understand is the virus uses the cells of its host to replicate and to generate more copies of itself. And so it does that in both the upper and the lower respiratory tract. And once it's gone through several cycles of replication, there's a lot of virus hanging out. And so when we breathe, when we cough, when we talk, when we sing, when we shout at our kids, we're potentially expelling that virus from our respiratory tract out into the world. And that's what we would call shedding. So it's not unlike my cat's fur clogging up my air filter in my house.
Okay. But this is really a very, very contagious disease. So someone who has had it, who's contracted the disease, gotten over it, they are maybe kind of immune for it. We're not really, I won't use that word, okay, but we're not quite sure if they're not going to get reinfected. Can they, though, spread it? I mean, if they come in contact with someone who's infected, they maybe won't get it again or be sick, but could they transmit it to someone, Dr. Janz? Is that possible?
Oh, certainly they could. That's one of the things that worries me in particular, because it's much tougher to track when that's going to happen, and then it's much tougher, especially for us ICU doctors, to know when to marshal all of our resources to be ready for an influx of more patients. So it's a pretty difficult problem to deal with.
Now we're in the situation where we are seeing increasing in cases before. And when this all came down, our healthcare capacity, literally the infrastructure, was taxed. You guys did an amazing job, our healthcare community did, in keeping up with this and getting people healthy. Are we a little bit better off in terms of our healthcare infrastructure than we were at the beginning of this pandemic? Jennifer, what would you say?
Oh, yeah, I would definitely say yes, we are. And really, I can't say enough about not only my colleagues in healthcare, but the health systems and the way they stepped up, particularly in our local area. There were days where it was very, very close. We were very close to being saturated in terms of our bed capacity, our ICU capacity, and ventilator capacity. And there were a lot of really smart, intelligent ways that the systems prioritized resources, got resources where they needed to be, utilized whatever they could, and made it work. And I think now we are stronger than we were before. Unfortunately, our colleagues around the country are having to repeat the lessons that we learned 3 months ago, whether it's in Arizona or Texas or Florida, where their first peak was not as high as ours, but now is taking off really at an alarming rate. They are seeing the ICU saturations, the nursing shortages, the resource non-availability that we saw 3 months ago, and that really devastated New York and a lot of other places. And so it's really a cautionary tale that we need to be continually vigilant, as Dr. Janz said, because we do not want to go back to where we were, but we have to be prepared, in that eventuality.
Okay, I'm going to go round table 10 seconds each. What should we be prepared to do to stay healthy? Dr. Hassig, you.
Wear a mask.
Okay, that's concise. Dr. Janz, what do you say?
Wash your hands.
That's one thing that we hear a lot, and don't touch your face, right? Dr. Seoane?
It's wearing the mask and social distancing.
It's important because the virus is still here. We still need to be cautious. Jennifer, one last cautionary word from you. Avoid
Large gatherings with close contacts.
All right, all good information and advice from the doctors that we should follow. I want to thank you guys so much. This is our first program. We're going to be doing more, so I hope I can invite you guys back in the months to come, and I hope in the months to come we can start reporting more and more how science has progressed to help us handle this new coronavirus, because we've never experienced something like this before. Thank you so much. Really appreciate it. Till the next time. Right now, we're actually going to go up to a segment about face masks. Face masks are now part of our new normal. Dr. Calvin Mackie, who is the founder of STEM NOLA, explains how they do help protect us and why we should be serious about wearing them.
Hi, my name is Calvin Mackie of STEM NOLA, and I'm happy to be here today to talk about COVID-19 and the role that masks play in the prevention of the transmission of the disease. You've heard a lot about COVID. We don't have a vaccination to protect ourselves against disease, nor do we have the therapeutics to treat it. So the only thing that we can do in our battle against disease is mitigation. And mitigation comes in a different type of forms. We can practice social distance, keep 6 feet away from other people. Either you can wash your hands and you can keep your fingers out of your face. But more importantly, is that we're asking everyone to wear a mask. And masks work because they're a barrier. As a matter of fact, when I wear a mask, I protect you. When you wear a mask, you protect me. Now, let's demonstrate how masks work. If we were to take this lighter and just talk or blow, you can see how my breath blows the lighter out. But if I take a cloth mask and put on, it still acts as a barrier. Make sure that it's snug against your chin, cover your mouth and your nose. But even with a cloth mask, I can talk and blow. And you can see there's still some resistance from the mask from air leaving my mouth. And that's important because the virus is in the particles that may be projected from our mouth. So if we take a surgical mask, which is a very common mask that people wear, make sure you put it on correctly. And we test it with the flame. I can talk, I can yell, I can scream, and you can see that the mask acts as a barrier. I have to blow really, really, really hard to blow it out. And just like that, I mean, a mask protects us. And when you wear a mask and I wear a mask, the risk of transmission goes all the way down to almost 1%, which is negligible when we're comparing the transmission of the disease. Thank you all for listening.
And thank you, Dr. Mackie, Dr. Calvin Mackie with STEM NOLA. And of course, I want to thank our wonderful panel. They just really have imparted some great information that we really need to pay attention to. And so we here at WYES plan to continue this discussion about how we adjust to living in the new normal with a recurring series of programs about varying topics. And next up will be K-12 education. A lot of questions out there about how do we continue our kids' education during this pandemic and to keep our kids safe. Well, if you have some questions or ideas about what you think we should be covering, please email us at communityprojects@wyes.org, wyes.org, communityprojects@wyes.org. We'll keep you posted about our next program. So until then, stay cautious and stay well while living in the new normal. Thanks for watching. Louisiana women.